With this, we come to the last session of the day, and I think that will be all the conclusion, is S.K. Parashar's oration. I will request Dr. Shanmugasundram to kindly come in front. Ladies and gentlemen, I want to speak just a word about this oration. This is this third oration in the name of Dr. Parashar, who is a father of echocardiography, a very senior cardiologist, and is being bestowed upon. I'll request all the people to kindly come in front. Very Satish. Yes. Dr. Midda, can you just come on the dais? Dr. Midda, is it possible for you to come? Please. Very Shanmugasundram. Please come in front. It's a big honor. And see, oration is never given the last. But this we are giving it to show its importance. It is not only the persons on whom the oration is and on whom oration is given. A very eminent cardiologist, known not in India but all over the world. We feel very proud of Dr. Shanmugasundram being with us. And I will request Midda Sahab, who is a trustee of this organization, along with a lady, Lisa, please come forward to put on the medallion on him. Both the medallion on him. Take a photograph, please. And another medallion, I'll request Rick Levy. Where is Rick? Please come forward. And Jagia, Priya. One lady is very important, Shanmugasundram like them. Please. Please.
Thank you. Ladies and gentlemen, Professor Somasundram Shanmugasundram is being conferred
Satish,
the award for outstanding contribution of
please
cardiology
give a token
in the world.
of appreciation for the both oration as well as the outstanding contribution in cardiology in the world to none other than Shanmugasundram. Archana and all the three from Mulchand Med City, please come forward, including Dr. Apur Mittal, to give a token of appreciation on behalf of Brahma Kumaris to Shanmugasundram. I am sure he is quite enthused, having two medallions in his neck. He will speak better now, not hypoglycemia. Shanmugasundram, have your oration now, please. Who is leaving? Come. Yeah. We have got a very senior person who has come all the way from Australia. We will also welcome him. I'll request Lady Smita Mishra. Please come forward along with everybody else.
Ladies and gentlemen, Professor Shanmugasundram would be delivering the oration on imaging and pulmonary embolism. Professor Sundram, please.
Dr. Shanmugasundram, may I have your presentation, sir?
Thank you, sir, for the nice words. My sincere thanks are to this University of Divinity and Serenity, not only for having included me in the academic session, but also for having given me a nice, simple, elegant accommodation as well as a healthy food. I am the eldest in the family, but I have the privilege of having acquired two elder brothers from my professional contact. One is Dr. Chopra, without whom I would not have come up in my life so much. When I am in trouble, when I am not in trouble, I need his encouraging and motivating calls in the early morning, which keeps me going. The other big brother is Dr. Parashar. He is a friend whom I have chosen as my elder brother. He is popularly known as father of echocardiography in India, not for his academic achievements in the field of echocardiography alone. If you look at the way in which he has fatherly attitude towards his contemporaries as well as to his junior colleagues, the proof of it is a medical society has been going on for nearly 2 decades without any misunderstanding among members and without even an election being held to choose the office bearers. That is the nature of Dr. Parashar, very strong binding force for all of us. I am very proud to be a part of this academic event. If the mortality of acute pulmonary embolism has been brought down from 30% to 2 to 10%, the credit goes to the prompt recognition of this problem by different imaging modalities. Like any other imaging in any other disease, imaging in pulmonary embolism should help us to confirm the diagnosis, prognosticate, choose the appropriate treatment, and help us in following up the patients. This is the era of multimodality imaging. We have multiple imaging modalities starting from ECG chest X-ray, echocardiography, perfusion scan, CT pulmonary angiography, MRI, invasive angiography, and so on. Which one to choose and which one to follow with depends upon the pre-test likelihood of the patient, hemodynamic stability, is there any alternative diagnosis, and more than anything, local availability and local expertise. Before choosing an appropriate imaging modality, it is our duty to use one of the two well-proven clinical prediction rules to categorize the patient into low, intermediate, or high-risk category. People with low or intermediate probability will go for D-dimer testing. If it is positive, they will go for imaging. If it is a high probability clinical prediction, they can go for imaging straight away with echocardiography as well as CT angiography. Starting with the simple diagnostic tool, electrocardiogram is often abnormal but often non-specific. Sinus tachycardia, supraventricular arrhythmias, right atrial enlargement pattern, incomplete RVB, RV strain, so many things. This ECG describes the classical pattern described in acute carpulmonale, namely S1 in lead 1 and Q3 and inverted T in lead 3, called as S1, Q3, T3. But remember that ECG is very non-specific and may help you to exclude confounding problems like myocardial ischemia or myocardial infarction. People have used scoring systems based on ECG findings and correlated with the clot burden. Though initial studies were encouraging, later studies have confirmed that neither the ECG scoring nor the clot burden assessment could help in assessing the clinical outcomes because of the simple reason that the outcome of the patient is determined mainly by the underlying cardiopulmonary status, not just by the clot volume alone. Chest X-ray is like ECG, most of the time abnormal, but most of the time non-specific. Many different findings have been described: focal oligemia, wedge-shaped opacity indicating pulmonary infarct, prominent central pulmonary arteries, plate atelectasis, infiltrates, pleural effusion, elevation of ipsilateral dome of the diaphragm, and so many. But I view chest X-ray as one of the important diagnostic tools in the following way. A normal chest X-ray in a patient with severe dyspnea and hypoxemia, but without bronchospasm or cardiac shunt, strongly suggests pulmonary embolism. And it also helps me to exclude other simulating diagnoses like pneumonia or pneumothorax. Chest X-ray dictates which diagnostic modality I should choose next. This is the way chest X-ray helps me. If the X-ray is normal, ventilation perfusion scan may be useful to diagnose the disease. And if the chest X-ray shows shadows, VQ scan is not going to help you. CT is the diagnostic modality of choice. Coming to echocardiography, which is available everywhere, even at the bedside, there are many findings which are described in pulmonary embolism. Everything is based upon the pressure overload created by the clot, which is lodged in the proximal part of the pulmonary arteries. The pulmonary artery pressure goes up, but the unprepared thin-walled right ventricle is unable to cope up with the elevated pressure, so it quickly fails. So the pulmonary artery pressure rarely goes beyond 50 millimeter of mercury. The right ventricular dysfunction quickly sets in, and if you are fortunate, you can demonstrate an embolus in the transit. Where does echo stand in the evaluation of a patient with pulmonary embolism? If you look at the recent guidelines from Europe, if the patient is hemodynamically compromised, if there is a clinical suspicion of pulmonary embolism, and if you could demonstrate unequivocal signs of RV overload with the dysfunction, you need not even have any other imaging modality, you can go for reperfusion treatment very quickly. But look at the other statement, diagonally opposite one. If the patient is hemodynamically stable, echo is not recommended as part of the diagnostic workup. Why is this? In low risk and intermediate risk people, the echo has a low sensitivity. Not only that, even in people with high risk clinical prediction, it reveals only the consequences, not the embolus per se. This 60-year-old lady, dyspnea and effort for 2 weeks, atypical chest pain, normal ECG, troponin was negative. She was sent for CT coronary angiography, but the radiologist found out multiple peripheral pulmonary arterial emboli. So this is the situation where echo is perfectly normal, but CT pulmonary angiography could identify multiple clots. This lady who had delivered just a week ago by Caesar, presented with acute dyspnea of 2 days duration, obvious signs of right ventricular overload, flattened septum, D-shaped left ventricle. If you could carefully notice the right ventricular contractile pattern, the apex contracts or seems to contract vigorously when compared to the free wall, the so-called McConnell sign, which is described in people with acute pulmonary embolism. Look at the TR pressure gradient is just 20 millimeter. That means PA pressure is just 30 millimeter of mercury. This is the reason which I mentioned earlier. An unprepared right ventricle is unable to elevate its pressure to very high levels. The recent diagnostic methods like 2D strain could confirm the presence of RV dysfunction. The same patient, the inferior vena cava is dilated, not showing any phasic variation with respiration. And interestingly, we could demonstrate an embolus in transit, which is trying to escape from IVC to go into the pulmonary circulation. CT pulmonary angiography confirmed the diagnosis, large thrombus burden, particularly in the major pulmonary arteries, and the patient did well after thrombolytic therapy. 3 days later, this is the situation. RV overload has reversed, RV function has improved. This is another example of a 60-year-old female who presented with a dyspnea of recent onset. Right ventricular overload is obvious. The PA pressure on admission was just 34 millimeter of mercury. After just heparin followed by oral anticoagulant, within 5 days of presentation, look at the right ventricle. Right ventricular contractility is restored, RA and RV size has become normal, and the RV overload no longer persists. But look at the tricuspid regurgitation gradient. After the patient has improved clinically, it's now 50 millimeter of mercury. Why is this discrepancy? Acute episode, large thrombus burden, RV is unable to cope up, it fails, so the PA pressure is low. Partial restoration of the flow in the pulmonary circuit, right ventricle has restored its function, it's able to generate pressure, and over a period of time, this elevated PA pressure is likely to come down. This patient with a thrombus in the right ventricular apex has another finding. The right ventricular base contracts normally while the apex does not contract so well, the so-called inverse McConnell sign, which is also described in people with pulmonary embolism. Remember, in people with pulmonary embolism, though pulmonary arterial hypertension sets in, the PA pressure is almost always below 50 millimeter of mercury. If it is above 60 millimeter of mercury, consider an alternative diagnosis, chronic PH or at least chronic thromboembolic PH with the superadded acute embolic episode. Right ventricular dysfunction not only helps you to prognosticate, it also tells you that thrombus load is heavy in people with right ventricular dysfunction. More than 30% of the pulmonary vascular bed is obstructed in people who present with right ventricular dysfunction. When you encounter somebody with dyspnea, RV overload, elevated PA pressure, the diagnostic problem is it acute pulmonary embolism or chronic pulmonary hypertension. As I mentioned earlier, PA systolic pressure of more than 60 millimeter of mercury almost always indicate a chronic problem. Presence of right ventricular hypertrophy indicate that it is always chronic. And the discrepancy between the myocardial performance index of LV and RV could also help you. Normal LV MPI with abnormal RV MPI indicates that it is of acute onset. Right ventricular dysfunction in the absence of right ventricular volume overload like ASD. If there is right ventricular dilatation, that itself indicates right ventricular dysfunction. But more precise methods of estimating the right ventricular fractional area shortening, TAPC, and global longitudinal strain by speckle tracking echocardiography would also help you to diagnose right ventricular dysfunction because it is a predictor of mortality, 6-fold increase in death rates. Coming to this regional dysfunction, which has been talked so much about in acute pulmonary embolism mecanal sign, apex contracts well while the free wall does not contract well. This is not a sign specific for pulmonary embolism. As much as 17% of people with chronic PH demonstrate this, and as much as 2/3 of people with right ventricular myocardial infarction also demonstrate this sign. Another peculiar combination, is also supposed to be diagnostic of pulmonary embolism. PA pressure not beyond 60 millimeter of mercury, and pulmonary arterial acceleration time less than 60 milliseconds. PA pressure less than 60, pulmonary valve acceleration time less than 60 milliseconds. 60/60 sign is also supposed to be indicative of acute pulmonary embolism. This study has looked at the features of overload, 60/60, and mecanal sign. A combination of all three would improve the sensitivity without affecting the specificity. Global longitudinal strain will demonstrate that in people with acute pulmonary embolism, in contrast to chronic PH, a distinct decline of global longitudinal strain, less than 18%, minus 18%, indicates that it is due to acute pulmonary embolism, not due to chronic PH, unless the chronic PH is in end-stage heart failure. And another feature is when RV dilates, it's not only in the body or the apex, even the outflow dilates well. In chronic PH, the hypertrophy does not allow the outflow tract to dilate. So if you have RV outflow dilatation, particularly when the systolic excursion of the RVOT is less, think of acute pulmonary embolism. Ancillary findings can also be identified by echo. Presence of PFO, presence of right heart thrombi tell you that it is pulmonary embolism, and it also tells you that the risk of people who have these ancillary findings is going to be more. Transesophageal echocardiography will help you to identify central thrombi much more effectively than transthoracic echocardiography. So having known all these facts, I'm of opinion that echo is the imaging modality of choice in pulmonary embolism, at least to start with, because it is inexpensive, easily accessible, and simplest to interpret, safest in many conditions like renal disease, pregnancy, invariably abnormal in high-risk people. It's abnormal in majority of the people with intermediate probability. People in normotensive pulmonary embolism, RV dysfunction occurs in about 40% of the people. These are the people who are likely to move to high risk at any time. So echocardiography identify this subset. So if echocardiography is not done in people with intermediate risk, we will be missing this important group. The value of venous ultrasound is not too high when you employ other imaging modalities like CT angiography. The findings are distended vein, documentation of thrombus, lack of compressibility of the vein. Remember that it has a very low sensitivity. The sensitivity increases if they have leg symptoms. Otherwise, the sensitivity is quite low. Coming to CT, definitely the imaging modality of choice because it not only tells you the clot burden, it also gives you indirect signs like mosaic pattern of the lung field, and it also gives you an alternative diagnosis if it is present. And another advantage of using CT angiography is you can combine it with CT venography without an additional contrast. It may be an one-stop imaging for both the leg veins as well as the lung. The problem with CT pulmonary angiography is it has started identifying even small emboli in the subsegmental arteries, the significance of which remains unknown. Most often it is detected incidentally when the CT scan is asked for some other pathologies. But people who have risk factors like heart failure, atrial fibrillation, or malignancy do deserve anticoagulant treatment. And the consensus is yet to be arrived in this condition. Canaldi index is supposed to look at where the clot is, how much lumen is obstructed based on the CT angiography. This will also gives you an idea about the, the burden as well as predicts the right ventricular dysfunction. Coming to the perfusion scan, most of us have started using only echocardiography and CT pulmonary angiography, but there are certain situations where it is going to be helpful. A negative scan excludes confidently pulmonary embolism. A high probability scan indicates that it is very likely to be pulmonary embolism, but inconclusive results are there in nearly about 1/3 to half of people who present with pulmonary embolism. As on today, VQ scan is indicated for certain people. For example, if you are concerned about increasing the chances of breast carcinoma in a young female, you can go for VQ scan, and if there is suspicion, you can go for CT imaging. If there is contraindications for CT pulmonary angiography, this may be utilized. Magnetic resonance pulmonary angiography has not matched up with the results of CT pulmonary angiography yet, because even in this modality, as many as 30% of segmental and subsegmental pulmonary emboli get missed out. Coming to pulmonary invasive angiography, it demonstrates nicely the embolus in the lumen of the pulmonary arteries. Miller score is there to quantify the clot burden, but now this is used only when you are aiming at catheter-directed thrombolysis or catheter-directed therapies for acute pulmonary embolism. With echo and CT pulmonary angiography, most of the people with acute pulmonary embolism can be appropriately diagnosed. To sum up, if somebody comes to me with unexplained acute dyspnea, I will go for pre-test likelihood by using some algorithms, either Wells score or Geneva score. If they belong to low risk, this is little different from the guidelines. This is my choice. If it is fitting in with the low risk category, do D-dimer. If it is elevated, go for imaging. If it is normal, it virtually rules out pulmonary embolism. If the patient belongs to either intermediate group or high risk group, I will go for an echocardiography immediately because it can be done in no time. If echo demonstrate right ventricular dysfunction, regional as well as global, elevation of PA pressure, and if you are fortunate, if you catch up with some embolus in transit, and you are sure of the diagnosis, if the patient is too sick to go for CT pulmonary angiography, go for thrombolysis. If the patient is reasonably stable, go for CT pulmonary angiography, get it confirmed with the CT pulmonary angiogram. Then you categorize them into two groups, hypotension and no hypotension. If the patient presents with hypotension, thrombolysis. If the patient has no hypotension, and if right ventricular dysfunction is there, if the biomarkers are elevated, you may go for thrombolytic therapy. Others will go for only anticoagulant therapy. What would you do with the group, low risk group with positive D-dimer and intermediate risk, echo being normal? I will invariably go for one of the two scans, VQ scan, selectively used in people who are young, who are females, particularly those with normal chest X-ray. I will go for CT pulmonary angiography immediately if there is an abnormal chest X-ray, people who are old, and people who have marked elevation of troponin and BNP. Thank you very much.
Thank you very much, Professor Shanmugasundram, for your most outstanding presentation. We are very grateful to you for coming all the way and giving a very, very important message on pulmonary embolism and DVT. Let's give a big hand to Dr. Shanmugasundram. With this, I hand over the mic to Dr. Satish Gupta to start the proceeding of the valedictory program. Satish.